Go ahead.
Gentlemen, good evening. I am pleased to see that Dr. Orson Austin is in our midst tonight. And by popular request, we asked him to address the topic of arthritis. Many of you have been complaining, whether it's truthfully or not, that you have old football injuries, that you want to know if that's the cause of the arthritis. Well, tonight you'll have that question answered and a lot more. Orson, on behalf of the guys, thank you for continuing to do these topics on a regular basis. And we're very much looking forward to your presentation tonight. The microphone is yours.
Okay, guys, thanks. I know your time is valuable, and I appreciate the fact that you guys continue to come out to these meetings, and particularly to help me blavigate just a little bit. So tonight I'm going to focus on arthritis, and I'm going to concentrate primarily on osteoarthritis. I'm not going to, I'll touch just very briefly on rheumatoid arthritis, but the reason why I'm not going to say too much about rheumatoid is because most rheumatoid arthritis is not managed, at least in the United States, by primary care physicians. Most rheumatoid arthritis is managed by rheumatologists. So when I diagnose someone with RA, as we call it for short, I usually get them to see a rheumatologist right away. So, but we'll just touch on it very briefly. All right. So as with anything, we'll go over some of the risk factors for osteoarthritis, and at the end of this presentation, I think you'll be able to state a few of the treatment options for osteoarthritis. At the end of the day, the overarching objective is just to get you to know at least one or two things that you didn't know before. So if I'm able to do that, then I would say this was a successful presentation. So I'm hoping I'm able to do this. We're gonna start, however, a little bit different today. This man to the left, Dr. Guru here, he's the one who asked me to do this presentation. And then he doesn't show up. So when you guys see him, razz him a little bit for me. The other thing I wanted to follow up on, so I'm gonna do a little preamble tonight, start a little bit differently. Before I get into the meat of the discussion on arthritis, I did want to follow up on the discussion that we had very briefly on coconut oil and cholesterol. And the reason I wanted to do that is because, you know, it's a hot button topic right now. I think it was Govind who said coconut oil is being championed as the new in thing that cures everything. So I think we should kind of know about this. So I was gonna put Gaurav on the spot, but since he's not here to speak for himself, I'll for those of you guys who may not have heard the discussion, when Govind talked about coconut oil, I said, I don't know about that. Lots of cholesterol. And Dave said, well, that doesn't make any sense because it comes from plants, right? So since plants don't have cholesterol, how could you then say that coconut oil has cholesterol? So let's talk about that for a few minutes before we get started on arthritis. So coconut oil looks like this after it's been hydrolyzed at room temperature. So can you guys think of any other oil that looks like this?
Lard or something like that.
Aside from lard, right?
Oh,
Although
okay.
lard isn't really oil, right?
But
Oh,
margarine,
okay.
maybe?
Yeah, maybe margarine. Margarine might be the closest thing. But now they have a lot of soft margarines and stuff, which obviously they're messing with it. But the reason why coconut oil looks like this is what? Why do you think it looks like this? How are they so easily able to get coconut oil to look like this? Anybody?
Additives, I don't know. You know,
Okay.
things that preserve it. I don't know.
All right.
Boiling point, melting point, or
Okay. Well, the reason is coconut oil has a lot of saturated fat. All right, a lot of saturated fat. So the question then becomes, if I said to Dave, coconut oil raises cholesterol, he says, well, that doesn't make sense because coconut oil comes from plants, all right, and plants don't have cholesterol. He's right about that. So so I said, I don't know about that. Everything I remember from my studies said that coconut oil has a lot of cholesterol. So the reason is coconut oil, and this is from Harvard, by the way, Harvard School of Public Health. And I'm not going to read the whole thing, but the bottom line is it raises harmful LDL. So remember when we talked about cholesterol before, the LDL is the bad cholesterol. So L for low, the low one is bad. The HDL is the good cholesterol. H for high, the high one is good. All right. Um, so there's no question in the medical community that most of the experts feel that, unfortunately, and it doesn't give me any joy saying this because obviously growing up in a tropical climate, I want coconut oil to be something that's healthy, but the data and the evidence actually says something different. And the reason is coconut oil, even though it's promoted as a heart healthy cooking alternative, that's really a myth. All right. It raises cholesterol levels. And even though it comes from a plant, it raises cholesterol levels more than the other plant-based oils like olive oil, canola oil, et cetera, et cetera. So this is from the Mayo Clinic. So two well-established institutions, both Harvard and the Mayo Clinic. It's pretty convincing that coconut oil is not as healthy as we would like to think.
Orson, question.
Yes.
Okay. I am seeing a lot of ads coming up on my phone touting the value of olive oil and even a shot of olive oil on a regular basis.
Yeah.
Why is that so much better?
Here's why. Thanks for asking. So as it relates to coconut oil has 92% saturated fat.
Wow.
I mean, think about that, 92% saturated fat.
Wow.
I compare that to olive oil with 14%, canola oil with 7%, et cetera, et cetera. So most of the experts feel that the best diet from a health perspective right now is the Mediterranean diet. And guess what type of oil they use in the Mediterranean? Olive oil. Yeah. So olive oil, most of the experts feel that olive oil is actually the healthiest oil.
Hey, Orson, can I
Yes.
interrupt with a question?
Sure, absolutely.
So if you use olive oil and in like most of us, at least let me just talk for myself. If I use it, say, without heating it up at all, over a salad or over, some sort of Italian dish, that's fine. That oil does break down under relatively low temperatures. What is the effect of the oils breaking down under temperature?
Yeah, so it has, and you chemists, all the guys who are chemistry majors, you probably know this.
I am not one.
But, okay. So for olive oil is a type of oil that's good for stir frying, but it's not gonna hold up for deep frying. Okay, it has to do with the boiling point, et cetera, because it burns if you put olive oil on a really, really super hot fire, it's gonna break down. So still frying with olive oil is fine. Using it raw is fine. If you have a high quality olive oil and some nice healthy bread, man, it's fantastic. So you
So
can heat it up very slightly, but and still frying is fine. But olive oil is not the type of oil because of the boiling point that you would use for deep frying.
when it breaks down, are we into the area of carcinogenic type chemicals?
No, it just doesn't taste right.
Okay.
It's not gonna taste good. Yeah,
Right.
but it's not carcinogenic. Yeah.
Okay.
Good
So
question. Good question.
I have a question, Orson.
Sure.
We talked about coconut oil, but what about other coconut products like coconut water?
The water
Have you
is
tried
fine.
that?
No. The water
Uh-huh.
is fine. Coconut water is fine. It's specifically the oil. Yeah. Don't be scared about drinking coconut water.
Okay.
No question.
All right.
But do look at the sugar content of some of the products though.
Yeah. Well, it's funny you said that. I was gonna save that for a different talk, but since you brought it up, Peter. So here's the thing that really makes me sad, and I'm not trying to be funny. I'm serious. Guess which tropical fruit has almost the highest level of sugar?
Balata.
Mangoes.
Mangoes has tons and tons of sugar. So again, everything in moderation. Nobody will say stop eating mangoes, but probably sticking with one rather than trying to eat 5 mangoes makes, mangoes are really high in sugar. What type of fruits have the lowest amount of sugar? I talked about this. I'll see how much attention you guys were paying when we talked
Then
about
a quiz now.
I'm thinking Janet,
I don't know about anything about cheddar in terms of sugar content, but it's the berries. So here's the unfair part of this, right? The unfair part of this is, and it probably has to do with, and Roger used a big time historian, with the plants that many of the oppressors brought to the Caribbean. And obviously the climate has something to do with it, because obviously you're gonna have to bring plants that will thrive in a tropical climate. But a lot of those things are just super sweet in terms of fruits specifically. So a lot of the tropical fruits have a lot of sugar. Maybe the sun has something to do with it. I haven't read that anywhere, but it makes logical sense to me. But the berries, the thing about the berries that makes me sad is that berries are the most expensive fruit. So if you tell someone who is living on minimum wage to go buy a bunch of berries as their fruit, they'll say, what? I'm supposed to pay $7 for 2 ounces of blackberries, especially if it's organic. If it's organic, that's what you're gonna pay. So it seems unfair that the healthiest fruits are the most expensive ones. And the ones that I had asked Lyndhurst, he said there are berries in Trinidad, but I had never seen
Yeah,
berries in
when
Trinidad.
we talk, Roger is up. But when we're talking berries in Trinidad context, we're really talking about dongs and these kind of things.
Okay.
Okay. Good.
So also a couple of things. I know, like you talk about berries. I know my wife had a recent experience where her doctor said, "Oh, berries are good," but and so she was enjoying blueberries. But then
Okay.
blueberries apparently have more sugar, or significant more sugar, than blackberries and raspberries. So then she's free to eat the raspberries and the blackberries, but not so good with the blueberries.
Yeah, but everything is relative, right?
Yeah.
It may blueberries may have more sugar than the other berries,
Right.
but they don't have, compared to like mangoes and Bing cherries and stuff, they don't have close to the amount of sugar as those.
Right. And
So I would say to your wife, she shouldn't
What about
worry about
bananas?
eating blueberries. Bananas are high in sugar.
Yeah.
Bananas are high in
Pineapple as
sugar.
well.
And
Pineapples are high in sugar. Yeah, so that's exactly what I'm trying to say. A lot of the tropical fruits, unfortunately, are high in
If
sugar.
I could say something also, maybe you could comment on this afterwards, right? I mean,
Sure.
sometimes
Sure.
we get caught up in sugar, but my view and what I've read and what I kind of live by too, is that sugar is not always equal, right? We're not talking about sugar like taking a spoonful of processed sugar. So when you eat fruits that, and of course, don't go eat 10 mangoes, right? But at the same time, if you
Sugar.
eat a whole fruit that is sweet, you're not only getting sugar, you're getting,
Fiber.
whole sets of
Fiber.
macronutrients and micronutrients and fiber that you don't get if you just eat sugar. So the problem we have, one of the problems we have here in the country, in the world actually, is really added sugar. And for decades, the US food industry has campaigned against including on the packaging the amount of added sugar to the product, even though they do it they're forced to do it in Europe, but because they have the politicians in their pockets here, they've gotten away with it. I'm only just starting to see the last year added sugar, as a tagline on amount of sugar. So it'll say 8 grams of sugar, including 6 grams of added sugar, 2 grams of added sugar. And that's what you really need to look at. Coconut water is naturally sweet, but if you look at it, it might have 8 grams of sugar in a serving, but 0 added sugar, right? So that's much better than anything you eat. Blueberries, you're getting all sorts of phytonutrients and stuff from the skin of the blueberries and everything else, but I wouldn't be concerned about sugar if you're eating a whole. I wouldn't be as concerned of eating 20 grams of sugar or 10 grams of sugar if you're eating it from whole fruits, as opposed to taking something that's sweetened with sugar or corn syrup and having the same amount of sugar.
Okay, yeah, I don't disagree with any of that, except with one caveat. People who are diabetic, okay? So for non-diabetics, you're absolutely right. I mean, fruits and vegetables are generally healthy products.
Yeah.
But unfortunately, many other brothers on the chat have shared that they are diabetic.
Right.
So
Well,
when you're diabetic, if you go see a diabetic educator, they do talk to patients about the importance of watching the amount of sugar they get, even from natural vegetables and fruits. So yeah, if diabetes is not a problem, it's less of an issue. And you're absolutely right. I would much rather get my sugar from fruits and vegetables than from added sugar or from cakes and ice cream and stuff like that. There's no question about that. And you're right. I mean, fiber and other products that you get from fruits and vegetables, hey, it's healthy. So no one in their right mind would advocate to anybody that they shouldn't eat a healthy portion of fruits and vegetables. But as they say in simplistic terms, everything in moderation.
Right.
Just don't go crazy with it.
Yep.
Yeah. All right. So go ahead, Raj. You have a question?
Michael.
I don't know whether cherries will be considered in a class of berries, because we may not have many berries here, but we have several cherries, right? There's a little yellow one, which is claimed to have a whole lot of vitamin C. There's another
Right.
red one. There was one of those outside my bedroom all years growing up. And there are governor plums and all these things, which are very nice and sweet, taste well, but also have fiber and a decent amount of vitamin C. And these things are all seasonal. So if you eat it in season, you aren't likely to eat too much.
Yeah. Agreed.
The other thing, this chart
And I would bet that those fruits have less sugar than, say, bananas and mangoes. So yeah. I mean, governor plums doesn't taste super sweet to me.
No.
But maybe my memory.
And one should, in moderation, right? Our citrus here are very sweet. We have lots in our yard, but I
Right.
eat one every morning.
And,
Right.
and Michael, I would imagine that piwa has a lot of fiber as well.
I think people has only fiber.
plenty.
That's
Yeah,
right.
but it is like
Beta carotene.
10 people as a year.
Yeah.
You see?
All right.
Uh,
So to
start
finish
with
up with this, go ahead. I'm sorry.
the start that you just took off.
Yeah.
I don't know how we judge the chart, before, we're looking at the small amount of saturated fat, but the other two, the two types of fat shown there, right? What is good and what is bad.
You go back to the previous slide, also.
Back to the previous slide.
Okay.
This
Yeah,
one,
how
yeah.
do we interpret it, all right? We have coconut oil, we have soybean oil, we have corn oil, and sesame oil. Those are very much available here, right? I'm sure we have all of those in our house right now.
Right.
They all have a low level of saturated fat other than the coconut oil, but they also have a high level of polyunsaturated and rising amounts of mono. How do we judge it? What is best? Olive oil has a whole lot of monosaturated fat. Right?
Sorry. Previous.
Does that make, is it that makes olive oil the best choice?
Everything, and George, you can chime in. Everything I've read and heard is that olive oil and canola oil, those are the two. In terms of the Mediterranean diet, it's olive oil that they use. So I hang my hat on olive.
Yeah, I mean, I see that a lot in the literature too, and I think Dennis asked pointedly about people advocating taking a shot of olive oil. I know I have family in Trinidad who take a shot of coconut oil, have them and the kids take a shot of coconut oil every day, and I try to dissuade them from that, but to no avail.
Yeah.
It comes back to the same thing, right? Why are you taking a shot of olive oil? If you really want olive oil is what, and you might notice terms I found out in reading about it. It's a monoisolate, right? You isolate one part of a fruit or product to make a product. So oil by itself is just part of the olives that you squeeze out from it. If you really want to have that much olives, eat olive oil. See if you can eat that amount of oil from eating olives, whole olives. And that's better for you than taking an entire shot of olive oil. One thing that Americans tend to do in general is that they have this feeling that if something is good for you, then a whole lot of it is better. And that's not always the case, right?
Well, some of that is driven by the entrepreneurial spirit.
Yes, of course.
Yeah.
Also right.
Yeah, there's no question about it.
I tend to use two oils. I use avocado oil for cooking because that has a high smoke point, and I don't see it on your list there, so I don't know the profile of it. And we use olive oils mainly for salads without cooking, just mostly in salads. And right now, tomato and mozzarella with olive oil and balsamic vinegar. That goes on pretty good.
Yeah.
I
use olive oil for stir frying too, and I like it in stir fry.
Yeah.
Dennis, you had a question?
Yeah, Orson, quick.
Yes. Yes, sir.
Quick observation and comment on it, right? When I look at what you have here, you're saying that coconut oil has less monosaturated fat than actual beef fat and chicken fat. And you're saying that coconut oil has more saturated fat than actual beef fat and chicken fat. That's true?
That's what the literature says.
Okay, and so if that's the case, I think that you could show that to people and say, well, hey, go easy on the coconut oil. Because it's like you're chewing fat.
Yeah, but what George said is correct, that it's not, the message is not you can't ever have coconut oil. That's not the message. The message is please be smart about it. You know what I mean? Be smart about it. So the next, Ian, you were gonna say something?
Yeah, I'm listening, and as somebody who has studied tropical agriculture, and I'm sorry, Govin and Dave not here, but this is loaded with lots of politics and trade matters because
You're talking
coconut,
specifically about this chart here
yeah,
or in general?
because the coconut industry was killed in Asia and killed in Trinidad, right? So that the soybean industry, oil industry would prosper. And Trinidad, coconut in Cedros and other places where the husk was more expensive than the coconut itself at one time. They were throwing away coconut jelly to make oil and using the husk to plant anthuriums. And from our end, what we were seeing, it was pure American blockage of coconut oil going forward and pushing especially the soybean oil. And it was, and we've
Right.
been, yeah.
Okay.
Hey,
So I'll tell you
hey,
what, in
what's-
the interest of time, because
Yeah.
I have to get to arthritis.
Yeah, I was gonna say the same
Yeah.
thing. I think
Yeah,
we
in
need
the
to-
interest of time, this
Yeah.
topic has generated a lot of interest. So we'll revisit this in greater detail when we have more time.
we need a single
right.
session on that. Yeah.
All right, yeah. All right, we got to move forward.
Yep.
All right. But the last thing I'll say is just in general, not necessarily as it relates to coconut oil. This is the last thing on this topic. Saturated fat, if you look at the cell to the bottom left, saturated fat in general raises LDL, the bad guy. All right, so we'll revisit this in greater detail later. All right, now let's talk about arthritis. So arthritis is obviously an important condition that should be of import to all of us because it's the most common cause of joint pain and chronic pain as we get older. All right, it leads to significant disability. More than 30 million people in the U.S. and I looked up Canada statistics. At least 6 million. How many people in Canada? How many millions?
36 or 37 million.
Okay, so you can see that's a pretty big percentage right there. And it's present in anywhere from 50 to 90% of us as we get older. All right. So arthritis increases with age. So as we all get older, most of us can expect to get some type of arthritis. Now, some people get more just mild arthritis, and unfortunately, some of us get more significant arthritis. And as you can see, the projections, now COVID has kind of decreased the lifespan in the US by 1.5 to 2 years. So, but prior to COVID, the projection was a continued increase in the millions of people who were coming down with arthritis, not just in the US, but across the world. So 30 plus million, and most people tell you in the United States that's an underestimate, and that most folks feel that it's close to 50 or 60 million folks in the US with arthritis. As you can see, this is a worldwide problem. But the interesting thing about this particular slide is that look at the gender difference. So women get more arthritis than men. Did you guys realize that? No, yes, not sure.
I never realized that.
Yeah. Why do you
but
think that? Why do you think that
I
is?
I know that in the older years, a lot of women have a lot of issues with hunchbacks and
Right.
maybe it's a deterioration.
And as the chart shows, that fact is is not based on where you are born, because regardless of where you are in the world, there's a higher propensity for women to get arthritis as opposed to men.
Orson,
Mm.
Yes, sir.
does that have anything to do with childbearing?
No, it has to do with the way.
Calcium, I guess.
No, it has to do with the laxity of the musculature and joints of women as opposed to men.
Okay,
Um,
and the other thing that's on this graph is that women in richer countries are more likely to have problems with arthritis.
yeah, I wonder if that has something to do with lifespan and stuff like that, because the richer countries are gonna have a higher lifespan, a longer lifespan.
I
Yeah.
don't know. I mean, the people in Oceania seem to have issues, at least the women there.
Yeah.
You know, the
I don't
people
know
down
much.
in,
You know what do you know about Oceania?
well, down in the Pacific, Fiji, these places down there, you know, west of Australia or east of Australia, I should say. Australia, New
Yeah, but
Zealand,
I would,
Solomon Islands.
yeah.
Well,
I would have to sit down and study the life.
There's a lot of poor people down there anyway.
There are a lot of poor people too in those areas. That's precisely my point.
yeah, Orson, and you will want to cross this by age for you to see if they really live in, if it's occurring in the older folks, right? So,
Right. In the interest of time, I'll skip this fact. Yes, I will do.
well, you remember a pattern of islands from Form 2?
Yes.
Hey, PK.
Yeah.
All right. So Trinidad, never fails to that how we always end up in the top 10 list. I mean, it's just amazing to me. So yeah, this is a direct quote according to the latest WHO data published in 2018. Trinidad and Tobago was 0.13% of total deaths, and when you adjust that by population, Trinidad is actually number 2 in the world as it relates to arthritis. And that's 2018. So we're not talking about something that's not recent. So Trinidad did make the not the top 10, the top 2 list in this particular instance. So there's the point is there's a lot of arthritis in Trinidad and Tobago.
I just have one question. What
Sure.
when you say deaths from osteoarthritis, what is that about?
Thank you.
I'll clarify it. I'll clarify it. So when you're filling out a death certificate, number 1, patient died of heart attack. Secondary, coronary artery disease. And then you'll put like, the last line is other diseases. The patient might have been hypertensive, but that didn't cause the death, might have had osteoarthritis. So the osteoarthritis would have been put down there at the bottom. It didn't cause death, all right, but it would have been on the death certificate because it's very unusual for deaths to occur as a direct result of osteoarthritis. So it would have been on the death certificate, and that's most likely where they got it from.
Okay.
All right. Thank you, sir.
Hey, Orson, can I interrupt you for?
Sure, Peter.
You may have given a definition and I just missed it. What exactly is arthritis? Is it inflammation in the joint? What is the?
Yes, so physiologically, you've heard the expression bone on bone.
Yeah.
That's what happens when arthritis is at its most significant point. You actually have the bone rubbing up against the bone. So you're losing the cartilaginous material that helps protect the joints. And you lose that, and the bone and you can actually see it and feel it. You don't actually need an X-ray to make a diagnosis of arthritis. Most of the times people do that, it's more confirmatory or because it's kind of standard of care in the community to do an X-ray. But really, if you want to be, when you read the data, it says that you don't even really need it. You can actually look at someone with severe arthritis. You can look at their knees and say, that's arthritis.
Hey, Orson, if
All
you
right,
have
so
someone,
what can we
if you-
modify? So yes,
if you have someone
go
streaming
ahead,
in the
Peter.
house, your internet connection is cutting in and out.
Yeah.
Ah, okay, I didn't realize that.
Person, it's
Yes, sir.
too much whining a factor in Trinidad, too much whining. I was thinking about it.
Orson, can I
How
ask
do I
one
know that
question?
the bones and all that?
Okay.
Can
Oh.
I ask one question which you may cover or not, but just in case you don't?
Okay.
Is gout considered a form of arthritis?
Yeah, that's gouty arthritis. So it is a form of arthritis, yes.
Okay.
But it's not, it's not, it doesn't compare to osteoarthritis in terms of frequency.
Uric
Yeah.
acid.
Yes, it's uric acid buildup, absolutely. All right, so if you guys want to hold on for a minute, I'm gonna see if I can make some changes to get the internet connection a little bit better. So I'm gonna
Okay, so I'm gonna
give me 1 minute.
I'm gonna pause the
Yeah, pause
recording.
the. Okay. All right. So obviously, as the name implies, modifiable risk factors are the things that we can do something about, and non-modifiable risk factors are the things that, hey, we can't change. Okay. So we like to concentrate on the things that we can change, and obviously, it shouldn't surprise anyone that the larger we are in terms of weight, the more the joint could potentially be impacted. All right. So repetitive knee bending and squatting. So jobs like people who are roofers, painters, people who are in occupations where they're on their knees a lot or they're squatting a lot. Those people are gonna have a greater likelihood of developing arthritis. And smoking, like almost everything else, smoking impacts rheumatoid arthritis definitely, and possibly osteoarthritis too.
Oh,
so, yeah.
Yeah, quick
The
question.
owner,
Quick
yeah.
question. What about typing on the keyboard? Because now we have a whole heap of children who are growing up with,
Yeah.
right?
So that might be more, and then you'll see more arthritis in the fingers or the hands.
Yeah, because this is what my doctor suggested, that I've been doing this all my life, basically. And now I'm paying the price for that,
Right. Exactly.
Especially with them big concrete hand you have there.
Yes, Peter.
So obviously, we can't do anything about our age. We already talked about the gender discrepancy, that rheumatoid is more common in women. Genetics, obviously, we can't do about anything about. And some Asian populations have lower risk. And this is one of the few diseases that we have talked about on these chats where it's more common in Europeans. So
also with the repetitive actions like knee bending and stuff, so the arthritis in that case would tend to be localized in
those
knee,
areas.
in the knee,
Exactly.
Yeah.
Exactly.
So the rest of your body, your fingers and all that could be okay, but you could be feeling it in your knees.
Right. So
Yeah.
those people are gonna get knee replacements more often. Yes.
Just one more quick question, because I
Sure.
was having this discussion with colleagues, and the things that you do in your use often catches up with you later on. So we were talking about karate and taekwondo and punching walls and so on, as youths practicing. Do these things catch up with you with, wear and tear on the joints?
Well, it
When you
could.
get
It all
older?
depends on how, an amateur is gonna have less of an issue probably than a professional, right?
No,
You
because
know, so
I saw a video of a young boy really kicking a pole, a metal pole, on with his bare shin until the pole bent in two. And I'm saying, this guy is gonna have problems when he grows up.
yeah.
You
Well,
know.
if you remember, since it's Olympic time, you guys remember Carl Lewis,
Mhm.
right? Yeah. Well, what events did he participate in?
He was the 100-meter guy, right?
Yeah, but what else?
Long, long jump, long
It
jump,
was
and
long jump also.
Yeah.
So guess where he had his arthritis?
His hips, I
His
guess.
hips.
Knees.
Yeah, they said he had the hips of an old man when he retired.
Oh, really?
So that repetitive jumping, because remember, it's not just the competition, it's the training, the practice. So yeah, so any type of jumping, that long jump
You,
activity.
you should talk a lot as well,
Oh yes,
huh?
yes. He's not one of my favorites for a whole variety of reasons. We'll talk about that later. All right. So obesity, lack of exercise. So what type of exercise do you think might be helpful for people with arthritis? And we're specifically talking about knee arthritis at this point.
Swimming.
Yeah.
Yeah, so what they call in the United States aquatic therapy, right? So we send a lot of these folks for water aerobics, water exercise, and we have several places in Cincinnati here, and where they have water exercise activity for people with arthritis and other related conditions. So knee arthritis is actually the most common arthritis. This is what we see most often. And all of these things listed here impacts the frequency and severity of arthritis. So the joints most affected are listed here. And as I said, the data actually says that the knee is the place most impacted. So yes, I was involved, 25 years ago in a car accident on a snowy day. And my neck has been impacted since that. And as I get older, there's no question that I have arthritis in my neck related to that car accident. But anyway, so the point is, even though the knee is the most common condition, I think everyone in this chat obviously knows that the hands and the hips can be impacted, but there are other places, even the toe, where you can get arthritis. And as was stated, if somebody has gout, the most common place for gout is where? Gouty arthritis.
big two.
But
The big toe. Yeah, the big
Okay.
toe is the most common place for gouty
Okay.
arthritis. Yeah. Now you can get gout in other joints. It's just that the most common place is the toe, but it doesn't mean that you can't get it elsewhere.
Question, Orson.
Yes, sir.
Back with that picture. If you notice that you're getting joint pains in multiple areas, right? Neck, lower back, hips, knee, wrist, elbows, is there an underlying cause, some disease that you might have if you're getting pains in multiple joints?
Yes, that's when you probably would want to touch bases with a rheumatologist. I mean, if I'm concerned that somebody has rheumatologic disease, and rheumatologic disease runs the gamut from people with lupus, people with rheumatoid arthritis, and people with other, what the rheumatologists call inflammatory arthritis.
Yes.
There are a whole bunch of inflammatory arthritic conditions that can cause you to have pain and swelling in multiple joints. It's unlikely that someone is going to have at the same time concurrently osteoarthritis and, like, 15 different joints. So if you see something like that, especially if it's associated with swelling, if somebody comes in and they says, oh, my hands are swollen and I can't bend them and it's painful, and and I'm feeling weak and tired and my neck hurts, then there's this stuff called polymyalgia rheumatica, all that type of stuff that could be the cause. So don't automatically assume if you have in multiple joints that it's osteoarthritis. It could be some other type of inflammatory arthritis. That's not necessarily osteo.
But,
Does that
yeah,
go ahead,
but talking about multiple joints, I had no idea about this arthritis situation, none at all. And then a few years ago, I got up one morning and both hands, the middle fingers on both hands were paining, just like that. I just went to sleep fine. I got up in the morning and these two middle fingers were hurting and they haven't really stopped since, which led me to go check out my GP, and, she said, osteo, did the test and confirmed and so on. And the point is, I said, well, how come, both hands? She said, that is how it manifests itself, usually on both limbs, pretty much in the same place. So I was very surprised about that, because okay, if it's in your left hand, it's in your left hand, but on both hands at the same time, what's up with that?
Yeah, I mean, you can get osteoarthritis on both hands. But they probably, one hand still probably would be worse than the other.
Yeah, yes, this hand.
Yeah, and the hand that your dominant hand will probably be worse than your non-dominant hand. And would that be the case with you?
That is the case with
me. Okay, that makes sense.
Concrete hardening.
So the typical symptoms of arthritis, obviously pain, morning stiffness. So arthritis, this is the other thing that makes me think arthritis. When someone comes in and says, hey, I got up and I was really aching. And as the day went along, things got better. And then the process repeated itself over and over again. So usually morning stiffness, and things tends to improve as the day goes along. All right. Osteoarthritis is uncommon among people less than 40. It's not impossible. I see it in some people less than 40 if they tend to be morbidly obese and stuff like that. But as a general rule, the older you are, the higher the incidence and frequency of osteoarthritis. One or a few joints, we already talked about that, can be affected. So you can have multiple joints, but once you start having arthritis occurring with fatigue, not only do I feel like my joints are swollen and painful, but I'm really tired and I'm having neck pain. That's when you really got to think, this might be more than just osteoarthritis. I got to go get this checked out. All right. So x-rays, as I said earlier, is not really required to make the diagnosis if somebody has typical symptoms. However, do most doctors, at least at some point, do x-rays? The answer is yes. But technically, if I'm taking a board examination and they ask me if it's absolutely required to make the diagnosis, the answer is no, it's not. So the main cause, osteoarthritis is the main cause of knee, hip, back pain in older adults. As people get older, by the way, sometimes, especially if someone lives on the second or third floor and there's no elevator, and they just had their knee or hip replaced, sometimes before they can get home because they can't get up to the third floor, even if they have had a joint replacement. And forget about if they have a fire in the house, then that would be a big major problem. So for folks who have a lot of disability post-op after the replacement of their knees, hips, a lot of those folks go for short-term rehab. Either some of the hospitals have dedicated rehab units, and some of the nursing homes have what we call SNFs, skilled care units, where people can come. I missed that.
That was some background noise from
Okay,
someone, I think.
skilled care units. So you I think it was Peter who had asked, well, what's really going on with arthritis? And as I said, it's the cartilage. So degeneration of the cartilage, that's the hallmark of arthritis. So sometimes you will see the expression or the phrase degenerative joint disease, that's really just a fancy term that really pretty much says arthritis to me. Now, the orthopedist may say, well, it means more than that. But in general, if you see degenerative joint disease, they're talking about arthritis. Go ahead, Raj.
Yeah, so one of the things I've noticed about me actually are two things. Bone growth and bone deformity. Okay, because if I were to put up my fingers now, you would see like this finger, going, at least the tip of it going in the other direction. Let me just put it up like this, right? If you would notice there as well, you see that growth on the joint, right?
Yes.
And
yes.
yeah. So
yeah, so
and
that's that's
really
a hallmark.
I really only noticed that after the diagnosis, really, because I was living my life,
Yeah. So a hallmark of osteoarthritis in the hands is when the cartilage is damaged and there's bone growth, and they call them nodes. There are nodes that form in the distal aspect. This is called the DIP joint. So the distal interphalangeal joint. So the distal interphalangeal joint gets inflamed and the nodes actually develop there. Okay, they have fancy medical names. I'm not going to get into that. Hebden's nodes and all that type of stuff. But yeah, so doctors call them nodes. So you develop nodes over that area. Okay. Now, when you start having deformity and other things developing in other aspects of your hands at the metacarpophalangeal joint, like right here, that's when we start worried. Well, this may, especially if it occurs with deviation of the finger. So instead of the finger looking like this, it's looking like this, and this is swollen and bent.
You need to
then
bring
at
your
that
hands
point,
into the camera.
we start thinking, oh, okay, sorry.
Yeah, cool.
At that point, okay. At that point, I was talking about this. Can you see?
Yes.
This joint. I forgot where the camera was for a minute. Sorry.
Okay.
That's when you start thinking this might not be osteoarthritis. This might be rheumatoid arthritis. So rheumatoid arthritis causes joint destruction and the deviation. When you see, if your brother doesn't mind using him as a guinea pig, if he can show us his hands, show us your hands. Put your hand up to the camera.
Where's the camera?
Well,
higher.
Okay,
a
put
little
your hand
bit
in front
higher.
of your face, perhaps.
What's that?
In front of your face. Beautiful. Bring it a little towards the computer. A little closer. Yeah. And turn your hands around. Good. Come back a little to your right, I guess. To your left, I guess. Yeah. Come back some more. A little more. Bring your hands in front of your face, actually.
Move your head back, right foot.
Okay, and up. Bring it up a little more, your hands. Okay, a little more, we're going good. Yes, a little higher.
This is like a police stop, boy.
Yes. And come back to your right a little more. Beautiful, excellent.
Yeah.
Guys.
So you can see it's more than just the DIP joint that's involved. You can see that other joints are involved too with rheumatoid arthritis. All
For
right.
those of you who don't know, I cannot make a fist. That's the most I can do.
Right.
I cannot go back.
Yeah, keep your hands up if you're making a fist, actually. Yeah, like that. A little higher. Yeah. Okay, cool.
Right.
On both hands.
Right.
Yeah.
How long have you had RA?
2008 to now, 13 years.
Okay. All right. So we'll touch a little bit on the management of that just in a few minutes. So if we pretty much convince someone has osteoarthritis, the main goal is to really help them with pain, do our best to try to at least slow down the progression of the disease. Can't really prevent it so much, but we can try to slow down the progression. We want to maximize function. That's why I'm a big physical therapy person. Some of my patients get upset with me because I'm always sending them for therapy, but I really believe in physical and therapy. And then you want to minimize disease-related complications, of course. So again, concentrating on things that we can do. Weight loss for osteoarthritis now, not rheumatoid. I'll talk way back on osteo. Weight loss can certainly help. I think there are a lot of the good and respected orthopedists in Cincinnati tell folks who are morbidly obese that they have to lose 10% of their body weight before they would even touch them. Now, regardless of what you feel about the ethics of that, it's not my rule, but it's something that's pretty standard among the better surgeons. Some of it is probably driven by the fact that people who are morbidly obese tend to have more complications from surgery, and more complications means that their data and their because the hospitals are tracking post-op complications closely in the United States, and they don't want their data messed up. And folks, there are many of the people who end up with problems post-surgery, joint replacement, tend to be folks who are larger. So they actually, one of my patients I just saw last week, she said she was told she had to lose 100 pounds before the orthopedist would touch her. Now I'm like, I just shook my head because I know there's no way this lady's gonna lose 100 pounds, and she has really severe arthritis.
How heavy is she, man? 10% reduction of body weight at 100 pounds is a hell of a
Well,
lot.
I think honestly, the point I'm trying to tell you, it's pretty obvious to me that that surgeon just doesn't want to operate on her, because I can understand if he said, hey, try to lose 20, 25 pounds. One, they have to lose 100 pounds. I think that's like, man, crazy. So anyway, we already talked about exercise, some of the things that we can do as far as it relates to that. So treatment of arthritis. So here is, I'm glad PK is here, because one of the things that most of my patients, you guys know what the non-steroidal anti-inflammatory drugs are? ibuprofen, Aleve, naproxen, those type of drugs are the drugs that we call non-steroidal anti-inflammatory agents. Okay, so those are the drugs that many people use. Because I do a lot of geriatrics, that's not usually where I start. And the reason why I don't start here is because many of the older population have baseline kidney disease. And kidney disease and anti-inflammatories don't go well. So I'm gonna actually call on PK to tell us what he talks to his patients about as it relates to kidney disease and anti-inflammatory agents, because this is important as it relates to arthritis, because many of my patients are like, why are you so stingy with your anti-inflammatories? And they have stage 3 or stage 4 CKD. And I'm like, when do you want to start dialysis? So do you have a spiel that you give your patients, PK?
Well, the typical patient who I meet already has kidney disease. So they're already on acetaminophen or Tylenol for the pain relief. And things aren't going well. And I give them a referral to see the orthopedic surgeon, because chances are they need to maybe have a knee replacement, what have you. And the first thing the orthopedic surgeon would say, well, I would suggest that the patient go on a non-steroidal, the joint will quieten down, or there's a new group of medications called COX inhibitors, Coxia, is an example. And if I write back and say, no, the kidney failure has gotten to the stage where there's stage 3 or stage 4 chronic kidney disease. And if you give them a non-steroidal, like ibuprofen, Aleve, and the like, chances are you can tip them over into stage 5 kidney disease, where lo and behold, now you're talking about you need to start dialysis. Now, you could get acute kidney injury, and if you stop the non-steroidal, there may be an improvement in the kidney function, but then the patient's back in pain. So that's always a dilemma. But by and large, these drugs are good drugs when used by doctors on the front line in young people. By the time they get to Orson or myself, these are the drugs we're trying not to have to prescribe because of all the side effects that these drugs bring along with them. So that's what I would say. If somebody is complaining of pain and I prescribe pain relief medication on 100 occasions, only once will I prescribe a non-steroidal or COX inhibitor. 99 out of 100, it's going to be something else.
Right. Thank you. I agree with that 100%. That's precisely what I tell my patients, who happen to be, many of whom happen to be older. So I usually start with Tylenol. All right. There was a time when we would tell people that acetaminophen, which is the generic name for Tylenol, that up to 4 grams of Tylenol is safe. Now we know that that's been decreased. So up to 3 grams of Tylenol per day is felt to be safe. And doesn't lead to usually liver injury, unless somebody is like alcoholic or something. So you do have Tylenol, acetaminophen can impact the liver for people who have liver disease, alcoholic liver disease and the like. So you do want to ask that question about alcohol intake. But one extra strength Tylenol has 500 milligrams of acetaminophen. So if you have somebody take 2 twice a day, that gets you to 2 grams. And I usually start there and see how people respond if for folks with severe arthritis. And if that doesn't take care of it, then I go to about 3 grams a day. And I never exceed 3 grams of acetaminophen.
Awesome.
Yes.
With Tylenol, they have a product that my doctor recommended for my shoulder rotator cuff tendinosis.
Okay.
was the Tylenol arthritis. Now, does that mean that the Tylenol arthritis has the NSAIDs, or is it
No.
some other thing?
No. It's a marketing gimmick.
Mhm.
Tylenol arthritis is just Tylenol with at a larger dose.
Oh, okay.
Yeah. It doesn't have any anti-inflammatory in it. It's
Oh.
just a non-steroidal anti-inflammatory, I should say.
Oh, because
in it.
I got the impression that she recommended that for the anti-inflammatory aspect of it, but now you're telling me they don't
No,
have any.
no.
Okay.
It's just Tylenol that's at a larger dose.
Okay.
Yeah, it's a marketing gimmick. Yeah.
Yeah, Orson, quick question.
Yes, sir. Yeah.
Are there some people who do not respond to acetaminophen, but do respond to, ibuprofen?
Yeah, but if your kidney function is normal, that's okay. So I would say that's fine, but just monitor your kidney function, which it requires a blood test, obviously. So make sure your doctor, if you're gonna be, especially chronically, we're not talking about someone who takes an Advil for a headache. That's not what we're talking about. We're talking about people who are chronically using these medicines every day.
Okay, so just as a guideline, you said that with the acetaminophen, you're not going above 3 grams a day if taken.
Yes, I am not exceeding 3 grams a day.
Okay, is there a guideline for the ibuprofen?
Well, for ibuprofen, we know that a lot of folks, and I am not a nephrologist, PK is. So PK, if I say something wrong, just jump in and correct me. A lot of folks, as we get older, our kidney function decreases, the GFR tends to go down. So I am very conservative. I start off pretty conservative. I don't want to be responsible for someone ended up on dialysis. I don't want that to be because of me. You know what I mean? So I'm pretty conservative. So if you came to see me, okay, so here's what we do. As folks get older, I maximize the acetaminophen. All right. Mm-hmm. And if Dennison comes back to me and he says, hey, I'm on 3 grams of acetaminophen, my knee still hurts like hell. Yeah. I'm like, okay. So I see what his kidney function is. His kidney function is normal. I put him on an anti-inflammatory. I said, okay, stop the acetaminophen. Let's go to your anti-inflammatory. But just so you know that every 6 months or so, we're going to be checking your kidney function to make sure this drug is not impacting negatively on your kidneys. All right. So I'll tell you a brief story. One of my patients about 10 years ago came in. I wasn't there, so they saw one of the resident doctors, the doctors in training. This guy was about 75 years old, and she gave him 800 milligrams of ibuprofen 3 times a day to a 75-year-old with baseline stage 3 CKD. He went into complete kidney failure, required temporary dialysis. And fortunately for him, after a few bouts of dialysis, his kidney function improved, so it wasn't permanent. But that was an avoidable error. You don't put a 75-year-old man on max dose ibuprofen. She actually sent him into kidney failure. And I'm sure PK has seen that at some point in his career. Glucosamine chondroitin. You guys have heard of it?
Yeah.
Yeah, on TV.
Yeah. So here's my approach to glucosamine chondroitin. For mild arthritis, I tell folks, hey, you want to try it? It's over the counter. You don't need a prescription for it. Costco, Sam's, Walmart, Walgreens, every pharmacy in the United States sells it, and Canada too, I'm sure. All right. And I'm sure it's being sold in Trinidad also. For someone with mild arthritis, and it doesn't really have a whole bunch of side effects. So I tell them, hey, give it a try. And if it works, great. For patients with more advanced arthritis, I don't find it to be very helpful. But as with anything else, since it's safe, even if it has a placebo effect, I'm good with it. So if somebody, even with advanced arthritis, if they swear that the chondroitin is helping them, I'm not going to ask them to stop it. You know, so I don't have a big problem with chondroitin glucosamine. But
Okay,
yeah.
for the past 20 years, I've been on and off this glucosamine with chondroitin. And I have serious problems with the crab shells or the lobster shells that they're made from. And I start getting red rashes all over. Do they do the combination from something other than them shellfish? Or that's, if you're allergic, you just...
So Dennison, here's my rule.
Yeah.
If you're allergic to something, don't take it.
Right.
So you really shouldn't take it.
Right. But you have to try different brands to see if you're allergic to them, right?
Peter is complaining about my hands, but like they're trying to turn you into a crab.
Have you experimented with any products like with glucosamine and chondroitin or not?
For me? No, I haven't.
Peter.
Peter
is in holder?
Can.
No. I don't know if you remember from the last time, but I had a doctor prescribe statins for me for years, and I never took them. And it's only when the talk of statins came up here that I decided to actually check the name and realize that was what they were prescribing. And then I had Orson warn me that they expire, so I have quite a few of those that I had to dump. But statins, and I take for high blood pressure, I take Coversil. Coversil is a brand name, I think, but I expect you guys would know Coversil and Lodipine.
Amlodipine, yeah. Amlodipine is an antihypertensive drug. Yeah.
So it's Perindopril.
Yeah.
High stress people.
So that's
yeah. Good. Hey, take your blood pressure medicine. That's all I'll say. Yeah. There are alternatives.
What about
Go ahead.
methotrexate?
Okay, methotrexate is not used for osteoarthritis.
Oh, okay.
Yeah. You're going over to rheumatoid. Yeah.
Okay.
Yeah. DP, I said Peter Holder, you say Peter Can. You what the mother, right? Okay.
I didn't know which, because
so I have used that as a supplement, but I have some pain from after I play sports. So the table tennis is very the way I play anyhow, it's tough on the knees. It's more a leg sport than it is an arm sport, believe it or not. So at this age, I typically I use bandages to play, and then I ice after. So
basically, Peter Holder is telling us he's a professional tennis player.
No, I'm not a professional. I'm a serious amateur.
That was a joke, Peter. That was a joke.
I know.
Okay.
Hopefully you're not using that dead green racket you had still, eh?
Well, the reaction I get out of you is worth it for me to keep that racket around.
and just to tell a story, sorry, Orson, but the reason I disliked that racket so much was one time we had table tennis competition in school. I don't know if you guys remember.
Uh-huh.
I set up the board in the auditorium. And the day I was supposed to play, I didn't know, so I didn't bring my racket. And like a fool, I borrowed Peter's racket. That was the deadest racket. I couldn't do anything with that racket.
So in other words, you lost.
You're blaming the racket now. You know what I'm saying?
You're blaming the equipment.
The racket.
Yeah.
It's
All right.
absolutely the equipment.
Yeah.
Mm,
All right. So alternative therapies, you'll hear about Tai Chi, acupuncture, and other things. And these things are fine. I have no problem if somebody wants to try some stuff like that. You also hear about some topical stuff. And by the way, there are topical anti-inflammatories. I would love to hear, PK, I'm not trying to put you on the spot, but I would love to hear how you feel about topical anti-inflammatories as it relates to kidney disease. Do you feel like they're much safer than the oral NSAIDs, et cetera, in preventing or minimizing the effects on the kidneys?
A lot safer in that the amount which is going to be absorbed through the skin is going to be less than what would be absorbed if it's taken by mouth. But I think part of the benefit with topical nonsteroidals is the placebo effect of knowing you're applying medication to the site of your pain. So you're getting that placebo effect, they put the medication on the site, and two, you're getting the chemical effect of the nonsteroidal. So I think
Right.
I allow it, but I tell them in moderation.
Right. And that's pretty much what I do also. I definitely feel a lot better about topical NSAIDs as opposed to oral NSAIDs in people with kidney issues.
Orson,
Yes, sir.
I'll give you a little story. I was
Okay.
working with my father. We using hammer and carpentry work.
Okay.
And lo and behold, I see my father pull it in a WD-40 and sprayed up some joints. I said, Daddy, what you doing? He said, don't worry, it's working good.
That is not a joke. That's not a
No,
joke.
Wow.
serious.
No, people really do that.
Yeah.
People really do that. Yeah, yeah.
Wow. That's
WD-40
amazing.
for the joints.
And they swear by it. Swear big time.
Wow.
Okay.
I did not know that. That's,
Yeah.
you see, you taught me something. You taught me something. Yeah.
Okay.
And some folks, not just specialists, but there are some primary care doctors too who inject steroids in the joints and high hyaluronic acid. So joint injections, a lot of for folks who are not surgical candidates, a lot of the orthopedists and primary care doctors would inject steroids maybe about every 3 or 4 months. So that's something that you will see being done. And obviously the gold standard for folks with severe arthritis from an osteo standpoint is joint replacement. So total joint arthroplasty, all right? So we see a lot of folks coming into the nursing facility, as I said earlier, for rehab after surgery. So if any of you or anybody that you know is going to have a joint replacement, the one thing to keep in mind is that joint replacements increases your risk of developing what we call in Trinidad a blood clot. The medical term is deep venous thrombosis. So you always have to watch out for that. Failed prosthesis, occasionally, I'd say maybe about 2 or 3 times a year, we see someone who has to go back and get a second surgery because they had a wound, a big time wound infection. The prosthesis has to be removed and replaced, that type of stuff. Occasionally, we see folks with pneumonia and urinary tract infections. But the mainstay is that these patients need physical therapy. If somebody is needs significant rehab, if they come to a skilled care facility for rehab, the way to get them home safely is definitely to be aggressive about physical therapy.
Before I go, a couple of things that work for me, if I might add.
Sure.
Non-conventional, really. When I sleep, okay, I go to sleep with my hands flat on the bed, not curled or anything, okay, and I find that helps, because before doing that in the morning, I got up with my hands hurting, but I noticed that when I do that, okay, I fall asleep with my hands spread out like this, open. I don't get any pain. The other thing too is that when I use my hands out in the yard or in the garden also, I always wear gloves. Okay, because you know anything that impacts on my hand hurts like hell. Okay, and the gloves do help in terms of things, you know, because you might pass and just hit your fingers, you know, on something, and that is painful, right?
Right.
So, you know,
Are
little
you
things
taking
like
any?
that do help. Huh?
Are you taking Tylenol?
No,
Acetaminophen?
no, no, I'm not on anything for the arthritis.
Okay.
And, you know, it's pretty well managed, I would think, up to now, you know.
Okay.
What's that, Michael?
With respect to home remedies, I am not an arthritis candidate, but my wife and I stopped doing ballroom dancing a few years now because she had
Started or stopped?
stopped because
Stopped.
we stopped doing ballroom dancing
Okay.
because she has a lot of trouble with her knees. I started feeling it myself, right? But I believe in coconut oil. I was going to talk about coconut oil just now because with all the bad things you say about it, you know, another use of coconut oil is on your skin. It penetrates your skin. And people have been using it as a good remedy for having nice skin for years. But I still use coconut oil on my feet, on my joints. This is even coconut oil that I use in my hair. Coconut oil conditioner, which is white to keep the hair from getting yellow I was talking about, right? Right? But I also use rough lemon, right? You have a rough lemon tree, and I put a slice of rough lemon in my water in the night. So I drink some in the night last thing. I drink first thing in the morning. They claim you should use it warm, but I use it room temperature. And since I've been using that rough lemon in water and the coconut oil, I run up and down these steps. I tell you, I have 13 steps between each floor in my house. I run up and down the steps. She still has some trouble with her knees because she's laughing at me with the lemon and all that. But it's obviously working, you know. So I don't know what scientific explanation that might have. The lemon and the acid in your joints and the coconut oil with whatever repairing of the cartilage. I don't know if that could happen. I do all my exercises. I do my walking. I do my stretching. I do my push-ups. I do my sit-ups, everything every morning. And I rub with coconut oil and I drink lemon water.
But you're not drinking the
I never went to the
coconut.
doctor for arthritis. I never had to take Tylenol, painkiller, or anything like that. But I use it every day.
But you don't know if that's because of the coconut oil, do you?
No, I use the coconut oil to help with that. But you know, I am pretty sure the coconut oil sinks into the joints. At least, you know, if my mind interprets it that way, then it probably helps, right?
Yeah.
But I certainly believe that that is one of the benefits of the coconut oil. I have a little eucalyptus in it in order to smell nice. Yeah.
But I'm glad we started the discussion with coconut oil then.
All
right.
oil in the coiler.
So
I think there's a different kind of oil.
some people also swear by cumin. How helpful is that?
Put some coconut oil on your fingers in the night. You know, rub your hands with coconut oil. Right? Because I really believe that at times.
You see, this is actually the benefit of scientific inquiry, because then you actually can prove it. Have to use a control, you know what I mean? And we don't go by.
Yes. Well, what I will say is there's something called, and PK alluded to it, the placebo effect. So, hey, if it works for you and it doesn't cause you any harm, you know, but we don't have any scientific evidence. But if it works for you,
as far as for me and the coconut oil thing, you know, it was recommended to me by the by the guy in the West Indian store, you know. He said,
But
"Take this, man, it's
Roger,
great."
Roger,
Ah.
Roger, that's the point I was trying to make. Coconut oil is recommended for like 100 different things now. It is a big marketing campaign for coconut oil. And you know, I'm just reporting the evidence as we know it today. Now, evidence sometimes changes. I have to be honest about that. But as we know it today, I'm just don't, you know, as they say, don't shoot the messenger.
Yeah.
I'm just telling you what the evidence.
Austin,
Good
don't
Austin.
Roger.
Can I add to that? I was in Trinidad and I was talking to a guy about my rheumatoid arthritis. He said, boy, you know what you should do? Put some razor blade in some water and let it sit overnight and then drink
Orson, you comment at us with this radical idea of following the science. I ain't this sort of shit. You know, don't come with that sort of stuff. That's only confusing matters.
Hey, Orson,
I
there's
understand.
two things I have. One is,
Okay, to you.
how about diet in your, there's nothing about diet in this presentation at all that relates to either slowing the development of the disease or
Well, the
exacerbating.
the diet is gonna be indirectly related to the obesity thing that we talked about.
Okay.
So there's no one particular food or anything like that. But the main thing is watch your diet so that you don't gain too much weight.
Okay. So the other thing I have is,
yeah.
there's a whole fad now. Well, not fad, but there's a big thing with the CBD creams. Any comment on that?
You know, it's good for everything. It cures cancer and everything else. Don't you know that? So I told you, man, the United States, it's people always trying to make a buck. But that being said, in all seriousness, we know that there are some experts who truly feel that marijuana could be helpful for chronic pain, for example, and stuff like that. So I wouldn't, you know, if someone has a terminal cancer and they want to smoke some weed, I don't really have a problem with that. You know, if somebody wants to, if that's going to make your quality of life better, that's fine. So I mean, so there is some evidence out there for stuff like that. But where I have problems is when people try to say, you know, use some CBD for everything. You know, it cures anxiety, it cures depression, it cures, you know, it's like, and those are some of the same people who refuse to get the COVID shot.
I couldn't let this pass, Orson.
Okay.
I'm going to paraphrase here. What they say is a young doctor starts medicine with 20 drugs for every condition, and an old doctor has one medicine for 20 conditions.
That's right. That is definitely true.
Orson,
yes, sir.
Okay, connecting with this diet thing, you did not address what Michael Redhead said about his rough skin lemon. And he talked about the citric acid with the lemon getting to the acid in the knee. You want to connect some dots there for Michael? I mean, you could teach you one thing tonight.
I'll say what the check is in the mail. Is that bitter lemon? Is that what you're talking about? Bitter lemon?
No, you don't know rough skin lemon?
Lemon.
Okay. What he's doing is putting a slice of lemon in his water.
Right. Oh, okay.
And saying that the acid intake is going to help his knee stop paining because his knee contains acid.
Okay.
Well, it's supposed to be to inject alkaline, because when these fruits go into water, they actually turn alkaline. they aren't acid anymore. So you are making the blood, so they say, more alkaline. That's why people take alkaline water now and all that sort of thing, right? Alkaline water has become a big thing.
Is that right?
Okay.
Is that right? Do you put, when you put lemon juice in water, it becomes alkaline?
Alkaline. Yeah.
I don't know what Ian might have to say about that.
I would like to know if that's true.
Well, I would be the final arbiter on all of this. When it comes to acid base, the kidney will regulate everything and send your pH back to normal.
Thank you,
All
PK.
right.
That is not an answer, PK. That is not an answer.
Let Ian say his piece.
Rough skin lemon has reached the stage of a normal drug in the pharmacy. And as a result of that, if you go to the grocery, one rough skin lemon at times in Trinidad is over $10 sold.
Wow.
That is where it has reached. Yeah.
So people,
No,
so
but-
people are using it just for medicinal purposes.
Yeah, that's what is well, one of the things that they say all the time. Rough skin lemon in the morning, water with your water, and everybody going with that theory.
No, but to be fair, I mean, most of our medications came from plants. So there may be something in it that is giving the desired effect. It's just the proof might not be there to show the connection. So it doesn't mean to say it doesn't work, but it has to be reproducible. You have to show it's dose related, who it works on, who it doesn't work on. So it may work on some patients, it may not work on other patients. That is working for you. As Orson says, it's not hurting you. Take it.
Yeah.
Take it.
Well,
Ian,
The next one.
At our control conditions in 21 King Street, Francisstown, we have two candidates, two test cases. Michael Webber and his wife. He takes
Right.
the Rustin lemon and he manages the two sets of treatment, and she doesn't, and she goes up the step one today, one tomorrow.
Hey, sample size too small, boy.
It is beautiful.
All two is not enough.
I have a question. What is the difference, Ian? Maybe you could answer this, between the rough skin lemon and ordinary lemon.
I still asking that question too.
Price?
Okay, let me answer.
Next year.
Again, the bottom line is that the rough skin lemon skin is be a little bit thicker, but the lemon itself is juicier. Okay, let's get back to the original question. If you put acid in water and use a lot of water, it will be a diluted acid. It could never be an alkaline.
My point exactly.
Yeah.
No, but isn't there something about acidic drinks and arthritis?
Orange
Like
juice.
if you take too much orange juice or grapefruit juice or whatever, that kind of compounds the, at least that was my thinking for a long time. I don't know if that is true or not.
I think that's an old wives' tale.
Okay.
I don't
Yeah.
think we have enough. I don't think we have enough time for Orson to debunk all of the internet things. So I think maybe let him talk about what he knows.
Okay.
Alright.
Hey, Orson, before when you wrap up, I had asked you last week to talk a little bit about the booster for the Delta variant. If you have time, if you could give a few comments on that, if you don't mind.
Okay. All right. All right. So just treatment guidelines, exercise. We talked about that as it relates to physical therapy, water therapy. We talk about weight loss, alternative treatments like Tai Chi and stuff. Tai Chi is like a wonderful thing. There's actually pretty good evidence that Tai Chi helps people from an emotional standpoint and stuff like that too. So topical anti-inflammatories are fine and better than the orals if we are worried about kidney disease. We talked about steroid injections. We didn't talk about many people with arthritis do need some type of aid as it relates to things like using a cane, using a walker, knee braces, that type of stuff might become necessary. All right. Sometimes even after surgery, canes and walkers and stuff become necessary. So this is just an algorithm that pretty much kind of talks about pretty much what we talked about. If we start down here, you can see regular exercise is something we want to start with acetaminophen, like I said, and only when acetaminophen stops working do I go up to the NSAIDs. We talked about that. We start NSAID therapy. There are one of the physical medicine and rehab doctors I used to work with. He believes in switching to a different NSAID if one doesn't work, and he swears that sometimes ibuprofen may not work, but naproxen might, you know, that type of thing. So so some people do switch to different ones. We talked about glucosamine and chondroitin. I don't think it works for severe arthritis. I think it works more for mild arthritis. Opioid therapy for people who have really bad arthritis. Somebody has end-stage arthritis and they're not surgical candidates. Then sometimes we don't have a choice but to give them narcotics.
When you say end stage arthritis, what do you mean?
Arthritis that can't get any worse. It's so bad that it can't get any worse.
But it doesn't mean like the end of their life kind of.
No, no. End
Okay.
stage just means as it relates to the arthritis condition. Yeah, as it relates to arthritis specifically. Yeah. High injections of either steroids or high hyaluronic acid. And then the final step is surgery. So I always tell people surgery is always the last resort. Unless something is an emergency, surgery is always the last resort. But we do have people obviously who require hip replacement, knee replacement, and shoulder replacement. By the way, shoulder surgery is no joke. The rehab time for shoulder surgery is pretty, you know, I've had patients who have had to rehab for 6 to 12 months after major shoulder replacement surgery. So I just let people know that shoulder surgery is certainly no joke. All right. So, and the last thing, just in terms of what I was trying to show before, the nodes that you have, Roger DePisa, Heberden's nodes, that's what those are called. That's exactly what you were showing us, okay? And rheumatoid arthritis, on the other hand, this is the metacarpophalangeal joint here. You see how that's, and you see how significant and swollen that joint is and how you can have deformities here. Yeah. So for patients, the last thing I'll say, and the only thing else about rheumatoid arthritis, is that if somebody gets diagnosed with rheumatoid arthritis, they need to be started on medicine called the disease modifying agents immediately, because we're trying, DMODs is what doctors call them for short, because we're trying to prevent this type of deformity from happening.
Yeah, my mother-in-law, Mrs. Adams, curious that Adams is on this slide, but she had rheumatoid arthritis and her hand pretty much looked like what's on the right here. And
right.
She was on methotrexate.
Right.
And also they gave her a cast. Okay, so we have to put her hand in this, sorry, not a cast, a mold. Okay, but you have to fit her hand into and, like, you know, tie the mold around so that her fingers don't move around and such. And I guess that was a sort of way of kind of counteracting the twisting of the fingers.
Hmm.
You know?
I don't have a lot of experience with the cast. What I do know is that the earlier you can get on medicines like methotrexate and all the newer medicines out there now for rheumatoid, the better, because we're trying to prevent this from happening. We do not want that deformity to occur. So we used to rheumatologists used to wait, and now they do not wait. As soon as that diagnosis is made, you have to get them on the DMOD to help prevent this from happening.
Could
All
I
right.
say a few things about RA?
Sure, go ahead. Go ahead, Redford.
Just to let people know, I have to have a blood test every 3 months, 3 or 4 months. Okay? That's one of the things I have to do. Secondly, I am on 2 medications. My condition is stable. I had an appointment this morning with my rheumatologist over a phone appointment, and we have decided to cut back on my medication, one of my medications, 1 tablet a week. And for the doctors, it's leflumonide. I was having that two a week and so on. The other medication, he's also been cutting back on that, the hydrochloroquine and so on. But I'm good as far as the pains and all that stuff. Once in a while, I'll get pains in my shoulders or elbow. And what happens is I go to bed normal, just like you guys, and about 2-3 hours later, I get this sharp pain in one of those areas. I get up, sit up, within 5 minutes, it goes away, I go back to bed. That's how I experience my pain with RA. I don't get pain during the day. It's only when I go to bed in a, what do you say about it, a stable, static position, right? You wouldn't know that I cannot make a fist unless I tell it to you. But I do everything that I normally do. Right? Just to give you a sense of someone who's living with RA.
One quick question, Radford. The blood test is due to the medication that you're taking?
Yes.
Yeah, the medicines can cause side effects, yeah.
Yes. Not only that, but I also have to get my eyes checked because I'm taking certain medications for RA.
Yeah, so medicines like Plaquenil can affect the eyes, so you need to see your eye doctor regularly on some of these medicines. Some of these medicines can also affect the liver, so you have to get your liver enzymes checked, your white blood cell count checked, et cetera, et cetera. So yeah, so that's why I said we leave rheumatoid to the rheumatologist, because and it's primarily because it's a more complicated disease to treat, and many of the medicines have significant side effects. So we leave the rheumatoid stuff to the rheumatologist. I make the diagnosis and then I promptly ship them out to the rheumatologist. All right, I'm gonna end there.
Okay.
As
Thank
it
you.
relates to osteoarthritis and rheumatoid arthritis. Yeah, no problem, Raj. I just wanted to get to, yes.
Yeah, wait. Wasn't
Okay.
Stop sharing so we.
Okay, yeah.
Better.
Sorry.
And nice, good. Go ahead.
Shall I continue the recording or?
I think yes, because
Okay.
this answer might be of interest to many.
Everyone, okay.
Yeah. So PK can help me out with this too. Okay, so so by the way, so just for anyone who has been asleep at the wheel, COVID is raging its ugly head again, not just in the United States, but throughout many parts of the world. And it has to do with what Peter Holder talked about, the Delta variant. All right. So in the United States, they're calling it a pandemic of the unvaccinated, because obviously it's the people who are unvaccinated that are honestly responsible for the situation that we're in, right now. So in terms of booster shots, we were hearing different things. I believe the WHO is saying that it's highly likely that we'll need booster shots. The CDC and Dr. Fauci, et cetera, they have not stated definitively that booster shots are inevitable. Common sense tells me that we will need booster shots at some point, but it's not the party line thing yet. It may not happen this year, but if it doesn't happen this year, I think it's going to happen next year, that they will eventually require booster shots. Now, the WHO I read today are saying that we should hold off because we need to get more of the world vaccinated before we start talking about, giving extra shots to folks, which makes sense. So we need to get folks caught up to speed. So I think this is my personal opinion, and we'll hear what PK says. My personal opinion is that eventually we'll need booster shots, but I don't think it's going to be anytime within the next few months.
All right. Whenever a virus multiplies, divides, and spreads, with multiplication, you have transfer of genetic material, and mutations can occur. And we can take an analogy from the influenza virus. Every year you get a flu shot, because the virus going around this year is slightly different from the virus which was going around last year. And part of the virus which triggers the immune response, we talk about the antigen. So what we say is there has been an antigen drift from one year to the other. And because there was a drift in the antigen, you would design a vaccine that will cover that drift. The problem is, if that drift is too large, it's no longer a drift. It becomes an antigenic shift. And therein lies the issue of variants. So we have a Delta variant. And then you're going to get a drift. You'll have a Delta 1, a Delta 2, a Delta 3, a Delta 4, a Delta 5. But at some point in time, you're going to go to Epsilon. So you're going to have an Epsilon variant. And that's going to behave like a different animal to the Delta variant. Now, the vaccine that we have going around in Wuhan, which was the Alpha variant, that still has enough coverage to handle the Delta, possibly the Delta 1, the Delta 2, the Delta 3, until you get to the Epsilon. It may cover even the Epsilon. But what if when you get to the Lambda, the antigen drift and shift and drift and shift is too large, where the vaccine, which was designed against Alpha, has lost its potency against the COVID Lambda? That is when you're going to be obligated to say, you must get your booster. All right, that's one. Two, I know they're doing studies and they're measuring antibody levels in recipients of these vaccines. Until such time that we get good data to show at what level of antibody in your blood you are at risk should you become exposed, the whole notion of giving a booster would not even come on my radar. The reason being, as long as your immune system is intact, and I say, as long as your immune system is intact, we're not talking about people who have had kidney transplants or who are on chemotherapy, that sort of thing. As long as your immune system is intact, you have memory to exposure from that vaccine. And even though your antibody level is low, it doesn't mean to say if you're exposed to the virus, you would be incapable of revving up your immune system to give a good response and give you protection. So all of those studies have to be done. They're ongoing. And at some point in time, I think we'll get good guidance But the vaccine shots which you're going to take to give people boosters now, if you take those shots and you give them to the unvaccinated, you would actually decrease the pool where the virus is mutating at present to come around to give you your Delta 1, 2, 3, 4, 5 variants. And that is where your money is better spent. Vaccinate the whole world. My opinion.
No, I mean that's
Thank you.
the
Thank you.
yeah
Well
that's
said.
the that's the opinion of the WHO, that you vaccinate the world before you start talking about giving boosters. That being said, it should also be pointed out that now obviously they have a vested interest financially, we know that, but Pfizer has come out and said that they think people will need a booster shots. So that's out there, and for those people who are not anti-vaxxers, that issue is going to keep on coming up until I think the CDC is going to have to eventually take a stand and tell us definitively, because there have been a lot of kind of hedging going on. So I think they're gonna, if they support what the WHO is saying, if the CDC supports what the WHO is saying, then PK is absolutely right. We're not gonna have a booster anytime soon. But as we talked about here, what, a few months ago, and as has been alluded to by PK, viruses mutate. So some of it depends on the mutation too, obviously.
Yeah, one
Peter
quick que-
Can had a quick question, Roger.
Oh, okay. Sorry.
Then we can go. Go ahead, Peter.
No, sorry, I was just saying bye to George.
Oh, okay. Bye, George.
Okay. Yeah, one quick question, because I know it's kind of getting late. It's 10 already. So I've been double vaccinated. I guess most of us here have been, but we're hearing about these breakthrough infections. Should I be worried? I mean, you know, being around folks.
No, you shouldn't. So I mean, you still have to be smart. But the good news for people who are vaccinated is that even if you get a breakthrough infection, the chances of you dying or being hospitalized with serious illness is like minuscule. So I think we just need to encourage the unvaccinated to get vaccinated. That's really the key.
Yeah. No, because I was just getting excited about some rough skin lemon and some coconut oil as well. So, you know.
Try some puncheon.
Yeah.
So I always think of it in terms of hospitalizations and death. And if something, if you can keep me out of the hospital or keep me from dying, that's where the money is.
Okay.
Awesome. Well, thank you very much. DP, any announcements for next week?
Okay. Next week we're gonna have the part 2, I believe, of the discussion on CAISO. Okay. I haven't started working on it yet. I have some thoughts in my head. Okay, put that stuff down on a presentation. Right, but once again, it should promise to be interesting. Right.
So Roger and Peter Holder, when are we gonna talk about steel pen?
Wow.
Okay, that's a good question. I don't know if Peter Holder wants to answer, but after Michael had a question, so go ahead, Pete.
I mean, I'll go probably sometime in September, but you know, I'm gone on vacation. I think not next week, but the week after. So sometime in September would be good. You know, if somebody wants to collaborate with me on that, I'll be more. Oh, actually, anybody wants to collaborate with me on that, I'll be more than happy to do a collaboration. On
Okay, so Hola, we are scheduled till the end of September, so we'll put you in October. Yeah, more
right.
time.
Okay, that works.
Nice.
Okay. Michael?
I didn't realize that it's quite October.
You have lots to talk about, apparently. So,
No, I just have to talk about crypto, like I said, right? Like I said before, everybody I talk to, I encourage them to get involved. And I will get some sort of presentation just so that people will realize that we need to get involved, right? I am in
Okay.
finance a long
So,
time.
yeah, so
Um,
Michael,
so long as you have a little bit of money to play with, whether it's 20,000, there's nothing to lose because Bitcoin and Ethereum have brought more profit than anything else in history.
okay,
Um,
so Michael, let me ask you, since this is time sensitive, next week in the half an hour preceding our 8 o'clock Trinidad time start, why don't you take 15 minutes out at that time and do something on the topic?
Okay, that could work.
Good. So
this
next
is
week,
this should be a preamble to something bigger, right?
Yeah.
right?
Yeah.
Yeah. But at
Yeah,
least you get your time sensitive presentation in next week, right?
Oh, good, wonderful. Yeah.
There's money to be made apparently. Radford? And
I
then
have, in the pre-discussion, we're talking about busy
Govind.
corner. And Govind
Yes.
he can tell us about the
You were
murder.
asked for what's going on in Busy Corner, man. We heard that they had some deaths and stuff, you know.
Yeah, DP, you could stop the recording there if you like.
Oh, yes.